Good afternoon, everyone, and welcome to this week's National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar. My name is Fiona Robinson, and I am the series host. In today's webinar, we will learn about community voices in research. This webinar is being recorded and will be available to the community beginning on Friday, February 2nd. We encourage you to ask any questions you may have today. You can ask your question by using the Q&A feature at the bottom of your screen at any time during the webinar. We will monitor these questions as they come in, and following our speaker's presentation, we will put your questions to them. Today's webinar will be presented by Maria Santaella, Vice President of Research Strategy at the National Bleeding Disorders Foundation. I'd like to thank Maria for joining us today, and I will turn things over now to her to get us started.
Thank you, Fiona, and good afternoon, everyone. My name is Maria, and like Fiona said, I'm the Vice President of Research Strategy at the NBDF, and I'm so glad you can join us. I'm going to be talking to you about CVR, a project very, very dear to my heart, where we hopefully by the end you'll understand how our tagline affects it. It's CVR experiences impacting the future. So of course, like we like to begin with everything that we do at NBDF is centered on our mission, which is the National Bleeding Disorders Foundation is dedicated to finding cures for inheritable blood and bleeding disorders and to addressing and preventing the complications of these disorders through research, education, and advocacy, enabling people and families to thrive. I have nothing to disclose other than my employer. So for the next hour, so a little bit less, we're going to be talking about what CVR is, explain to you what is it that we're trying to accomplish with it, how it works, what we've learned so far, and we'll have a few minutes at the end to talk about, to get some answers, quick questions and answers. So before I begin, just a little bit of background. So research has been a very important pillar at NBDF. You saw it mentioned in our mission. I have actually supported researchers for over 70 years. However, the research department is pretty new. It's only been its own entity since about 6 years ago when I was hired together with my colleague, Michelle Whitcup. And since then, we're really trying to identify what is the role of NBDF in research. And so we've come up with like 3 main points that I would love to let you know that. Number 1 is addressing gaps in knowledge that can improve the lives of people affected by inheritable bleeding disorders. 2, ensure that the lived experience drives and influences the research process. And 3, to promote equity, diversity, and inclusion so that all research findings includes all. So hopefully you will see how CVR very perfectly addresses all 3 issues. Throughout this time, though, through all these 6 years that I've been here, I have seen an evolution of the role of the patient, right, or the subject in a research trial to more of a subject matter expert and now a lived experience expert, or LEEs, like we like to refer them to. We love acronyms at NBDF. So these have had an increasingly, they've become an increasingly partner in research, but more at the leadership level. And this is evident not only the development of CVR when they helped us create it and build it. Since the very beginning, we held focus groups and talked to the community. But it also do other projects, the NBDF, like the National Research Blueprint, for example. So lived experience expert is a term that was developed by persons affected by these disorders. And for that reason, it's now how we call people affected by these disorders and their immediate families, of course. So when you hear us say lived experience experts or LEE, know that this was the transition that occurred, the evolution that occurred, and that this label, this term was actually the preferred label. And, as the name describes, this term, lived experience expert, actually recognizes their perspectives as being unique, as being a unique expertise, and also very important. So also, before we begin, I want to tell you that we are in the process of developing CVR version 2.0. So many of the things that I'm talking to you about are on development. And I say this because if you have any great ideas, or if you want to help us as we continue to develop CVR 2.0, you are more than welcome. We really want to build something that is hopefully will be useful for every single key stakeholder in the community. So what is CVR? CVR is a community-powered registry that centers research around the lived experience and addresses an important gap, the lack of LEE-reported information. It collects information through electronic surveys directly from LEEs, right? There's no middle person trying to understand or put in paper what they thought they heard, which is very important. It is all voluntary, as with any research project, and participants must be either U.S. citizens, must reside in the U.S. and be considered adults according to the laws in the state in which they reside. Interestingly, for example, in Alabama and Nebraska, you must be over 19 years of age, and in Mississippi, over 21 years of age to be considered, to be able to give consent. CVR offers participants way to become active partners in research and in their healthcare through a personalized dashboard. And I'll show you some pictures in a few slides. And this personalized dashboard displays participants the data that is collected. It offers information presented or published, aiding in the dissemination and implementation of this knowledge. Provides curated educational resources to promote shared decision-making, and connects participants with other research opportunities. It also helps identify research priority directly from LEEs. And I'll tell you a little bit about how we do that. So how do we do it? We're actually turning experiences into evidence, right? We're collecting the experience of the bleeding disorders, that lived experience, and but directly from them. That is something that is very unique, right? It's patient-reported outcomes, it's patient-reported information, or like we like to say in NBDF, LEE-reported information. Through it, we're gaining a much more comprehensive understanding what it means to live with these disorders, complementing other research efforts that have been in existence for a long time, but it mostly focused in clinical data, information that comes directly from the clinic, lab, diagnosis, imaging, things like that, right? The very objective measures. It provides a two-way communication. So it's not only that the LEE is providing research, providing survey responses, but we're also providing that information back, hopefully in a way that they can use for their own knowledge or for their own healthcare, for their own decisions. But it also connects them with other opportunities. So, and we do that through the personalized dashboard that I'm going to show it to you in a little bit. And it really centers that lived experience, that research on that lived experience that for us, as you heard, is very important because it's essential really to ensure that research findings are really relevant for everyone. It also helps us identify research priorities that are important to people by following trends and patterns. First and foremost, the security of CVR. So we have certain measures that we've taken into account through CVR, understanding that this is, data safety and security is of utmost importance. So, for example, we have a certificate of confidentiality, or COC, from the National Institute of Health. And what the COC does is that it protects all identifiable and sensitive information that is being collected. It makes it immune from the legal process, unless, of course, the participant consents. And this protection really lasts forever. In addition to that, we have the CVR has been reviewed by an IRB, an institutional review board, several times, and it has been given exempt status. Data is always reported in aggregate and de-identified matter. So it's not Maria, who is X age, with this diagnosis, is a group of females age from this, ranging from here to that, that have this type of diagnosis are reporting this much pain, right? So all in aggregate, all in percentages. The data, of course, is encrypted and transited at rest and is really stored based on the strictest industry standards. And what's new in CVR is that we're being a little bit more proactive to decrease the possibility of duplicates and discrepancies. We have an email verification process that ensures that, that that secures the information, making sure that it belongs to that one person. It has two-factor authentication. We'll talk a little bit more about that, but it's an optional feature. And last but not least, MBDF staff does not have access to patient-level information, whereas before there was one person that was trained in, the ethical conduct of research, of course, and that was me, that we had access to that information. We have really now created a barrier for us so that people feel a little bit more comfortable knowing that we don't have access to that. The access to that is limited to IQVIA, which is our vendor, to make sure that the registry is working as it should. And an experienced statistician that has over 4 decades of experience and is really well-versed and trained in the ethical conduct of research. So how does it work? All right, so first and foremost, where do we recruit? Because we're very interested in diverse representation. We go to anywhere that they invite us, different states, different cities. We work really, really closely with our HEDI department to ensure this happens. So I thank Dr. Carrie Norris and especially Karina Lopez, who are helping us in this endeavor. So we go to MBDF conferences and educational events. We go to chapter events, whatever chapter invites us, we're there. We're either presenting on research and the importance of contributing to research, especially as a rare disorder population. But we also table, and I don't know if tabling sounds like it's a made-up word. So, but we will also table and have giveaways and have the opportunity for people to ask questions one-on-one. We create awareness via social media and other mediums such as websites or newsletters. We use MBDF social media channels, so hopefully you've seen our posts about CVR, and more and more so, we're trying to go through the HTCs, recognizing that they could be a wonderful conduit. Initially, we didn't want to burden them with one more thing that they needed to do. But we're starting to have conversations with people that say, yes, I'll be happy to help you recruit. So it's definitely something that we're considering now. The first iteration of CVR was translated into Spanish, and eventually we'll do that with CVR with the next iteration of CVR. We're working towards that. All right, so how does it work? So one of the new changes in the CVR is that we're going to have to actually use a unique email address per person, right? They'll go to what we're calling the CVR landing page, where they actually read about CVR and have access to some information, including frequently asked questions. You'll start seeing a QR code in the top right of your screen, and that QR code is it takes you to that landing page. That person, after reading all that, decides, okay, I want to sign up. So the system, we go through an eligibility process. And the eligibility process, like I told you, we want to make sure that people are 18 years or older, or 19 or 21, depending on that state. But it also was to comply with GDPR and to make sure that we don't, include people who of European origin, or that they live in the United States from European origin, following the GDPR, right? The General Data Protection Regulation that protects the privacy of European Union citizens. So that all those process meets the eligibility. If that happens, then you're able to create an account. They verify your password. You'll get an email to your account to make sure, yes, this is my email, go ahead. You'll be allowed to set a password. There's an optional two-factor authentication, so 2FA. You can do it with an authenticator application, a text message to your phone, or an email to the same email address that you provided. Once you go through that process, if you want to go there, you read a participant agreement, right? We are IRB exempt, so we don't have to provide a consent, but we do provide an agreement with all the elements of consent. So in the spirit of transparency, you can read it, you can print it, you can email it to you, but once you agree to participate, then it's when you start the enrollment process. Once you enroll, you will you go through, then you have access to the dashboard, which I will review with you momentarily. All right, so after you enroll, you land in this registry dashboard. It's under construction. Every couple of months, we launch a new iteration of the dashboard. The next one will come in about a month or so, so the end of February. And in here, you will find your tasks, you will find missions, you will have opportunities to connect to other research opportunities, etc. So let's go one by one so that you can get oriented to it. So first, you'll see that my tasks are all the surveys that you will have there so that you can take them. So you have the baseline, in this case, the anniversary, and we'll go what those are. Next to that, you will have the missions. So missions will be hopefully you'll receive badges or medallions for any activities that you complete. And at the end, after a certain period, we're still coming up with the rules. What we want to do is, instead of offering cash incentives, we really want to connect that person back to the community. So we will be once a year providing or raffling, that's the word that I wanted to look, entry to our annual Bleeding Disorders Conference. So my tasks survey. So the service, like I told you, the enrollment is part of the first, how you get to the dashboard. It really takes about 5 minutes. It asks for names, email addresses, phone number, real address, like physical address, phone number, diagnosis. The baseline survey is a little bit longer. We think it takes about 20 minutes. Obviously, you don't have to do it in one sitting, but you can take it, in one sitting or a few. These questions are a little bit more in depth and with a new emphasis in social determinants of health. The anniversary survey will be taken once a year, and this is where, we're very similar to the baseline survey, but it will allow us to follow trends and patterns, right? These trends, the general direction of this data of how we follow it time to time, but patterns is anything that's recurrent, that is consistent, a consistent characteristic around, grouped by a different, by population. So it'll give us a little bit better understanding about that. We will and I'll also talk to you a little bit more about this, about other focused surveys, or maybe external researchers, or maybe even a more detailed survey study that we want to conduct. But these surveys are actually doing the minimum for us to really try to understand that lived experience and try to come up with questions that perhaps we haven't thought about it in the past, just because we were not aware of it. So questions that we ask in the baseline and in the anniversary sales, of course, there's some demographic like age, race, ethnicity, and diagnosis, but also social determinants of health. Like I told you, it's a little emphasis on trying to understand this because we know very little about how social determinants of health affects our population. So these are things like financial information, address, education, access to food and other items, like, for example, pads and tampons for menstruation, right? Insurance coverage, access to care, social support, quality of life. So that's the kind of thing that we're now really looking into. We want to know about the history of diagnosis. How long did it take you to get diagnosed? Any other comorbidities? So any other diseases or any other conditions that are, in addition to the bleeding disorders? We want to understand symptoms. How do symptoms affect your life? If there's a history of an inhibitor, what's your treatment regimen? Joint history, pain, gene therapy, mental health, physical activity. So you see, it's a vast categories, but it's really understanding, to try to get to what's really the challenges. What are we doing? What could we be doing to be helping our community? You will also have the ability to have my health summary. So you'll be able to print a summary of your history. You might be, it saves it in there in one place. You can update it every year, but it's an easy way to get it, either accessing on your phone or printing it and taking it to the ER or to any healthcare provider. This is going to be launched in a couple of months, not in the next release. We also have my data, and my data is when you have access to personalized data, and you'll be able to see survey responses, the aggregate responses of everybody else compared to the information that you've provided. You will also have external research opportunities. This is where we will be able to link participants to other research opportunities based on their based on the inclusion and exclusion criteria of the clinical trials. Right now, we're linking to clinicaltrials.gov, but we see a vision. We're moving towards a vision in which if there's other researching happening in the community that do not feed the clinical trial.gov categories, we can also connect people with those efforts. So I'm really excited about that. We will see my impact. My impact is anything that that has been presented or any data analysis that has been done. What are the conclusions? What have we learned so far? And I'll give you a few examples of that in the next few slides. And obviously, NBDF has incredible educational resources, so why not link in them? Why not curate them and link them in a way that makes sense? Again, I'll give you a little bit of the prototypes of what we're looking for. So data stories will now look like this. Hopefully they're a little bit more visually appealing. They're cleaner. We're coming up with what we're calling data stories. How does the data? How is this that I'm looking at? Why is this important? Like what do I do with this information? Perhaps pose questions to your healthcare providers or even to yourself as to your healthcare, right? These two examples about who's in the registry and where they live. But you may also see, the scales, the impact of pain scales or the interference from pain. These are two PROMIS tools that are included in the registry. So again, you can see by the color and the size of the squares, how many people have actually responded one way or the other. You can filter by each one of the answer options below, and you'll be able to tell what you answered to kind of like refresh your memory. Eventually, with time, you'll be able to track those responses over time. If we zoom a little bit closer, when you hover your mouse over a particular square, you'll be able to see, the percent compared to others, and you'll also be able to see what you responded over time, so that you can compare. If you are, part of the big square or the little square, and then hopefully come up with ideas as to what that might be. This is another way that we'll be displaying information. Again, we hope that it's a little bit more intuitive, a little bit easier to understand, and a little bit more, just a little bit more fun, I guess. Educational resources, again, linking to, to NBDF's educational resources, perhaps curated by, we're going to have filters by diagnosis, et cetera, et cetera. So it's another way of having access to the good information that we have without having to go to our website. But we don't want this to be an NBDF tool. We're building something that we hope is of use for not only NBDF, but and the participant, right? They get some tangible benefits to it, but also for external researchers out there. So internal research, for example, we recruit through CVR to our virtual and in-person advisory panels, which are focus group, and they can range anywhere from helping us develop educational resources to helping us design research studies, right? I mean, you can see the whole gamut of it. We also do data analysis and other studies and programs because, we can see what are the needs, what are the educational needs, what do we see, what kind of patterns do we see, and try to address and help people thrive with these disorders like our mission says. We also have the possibility of working with external researchers, whether it's in their own research stories or by querying our data or creating specific CVR surveys that we can use. So I'll give you a few examples of what that looks like. What have we used CVR for so far? Explain a few little tidbits of each of the projects. Of course, very high level, right? Not in great detail, but so that you hopefully get an understanding of what we can do with them. Before doing so, though, I want to talk about enrollment. So as we transition to the new platform, we took the opportunity to really scrutinize the data. We took a look at the identified information, of course, and noticed there were some discrepancies, noticed that there were some duplicates, sometimes even more. And So we created rules. We created rules to clean up the data. We purged about half of the sample, if we're, to be honest with you, because we recognize that it's really better to have clean data than a lot of data. So our numbers went down significantly, but we know that with this new iteration of CVR, with the measures that we have in line, we will be mitigating some of the issues that made it to where we were at that time. So, after a long year hiatus, I can tell you that because we really haven't had any efforts in enrolling. We're ready to enroll. We're ready to go back. And so, as of September, September of last year, we were ready to enroll, and now we'll really go to wherever you take us, wherever you invite us. This is a list of manuscripts and abstracts that we've done on CVR to date, and I'm just going to review a few of them to give you a feel for what kind of things we can do with CVR. So in 2021, we submitted an abstract that was accepted and that was published at ASH. And the title of the abstract was Bleeding Disorders Data Registry Reveals Racial Ethnic Disparities That Could Significantly Impact the patient journey. So in this particular data query, we used basically descriptive statistics. We just wanted to describe what we were seeing in our registry. We had, at that time, we had 772 people within the registry. We created two categories. What you will see is WCNH stands for White, Caucasian, Non-Hispanic. So we put them in one category, and we put everybody else in another category. And you'll see the numbers there, 261 and 511. And the other categories, of course, included Black, African American, Asian, South Asian, Alaska Native, African American, Middle Eastern, et cetera, et cetera. So anybody who had a combination of a multi-race identified. So, we saw that in education, for example, the White, Caucasian, Non-Hispanics, where 64% of them had reported having a college or graduate professional level education. Whereas the other category, almost 60% of them reported having a trade or vocational school level education. So discrepancies in education. When we looked at annual income, we saw that 57.5% of white Caucasian non-Hispanics reported an earning between 50 and 149,000, whereas 71% of others reported the earnings being more 35 to 40 annually. So again, a big discrepancy in annual income. We even looked at the midpoint of range divided by the number of people who worked, who lived in the household. And when we compared them, white, Caucasian, non-Hispanics had, the median was 31,000, about 31,000 versus 14 for the other category. Again, big discrepancy. When we looked at employment, white, Caucasian, non-Hispanics participants were more likely to be employed full-time, disabled, retired, a homemaker, or student, whereas the other participants, the other category, were more likely to be employed part-time, unemployed, or be able to work but were unemployed. Again, discrepancies there. Health insurance, 50.1% of white, Caucasian, non-Hispanics reported insurance through an employer or a union, while only almost 60% of the others did. And almost 77% of others reported enrollment in Medicaid or other public income-based insurance versus 13 of the white, Caucasian, non-Hispanics. So as you can see, we did see some discrepancies. Next steps on this is really looking at outcomes and looking at, what are these social determinants of health we could actually do something about it so that we can hopefully create that equity that we're within our community that we so want to accomplish. Another experiment was a discrete choice experiment that we did a couple of years ago. It was called Patient Preferences and Priorities of Hemophilia Gene Therapy in the US. It was published in Hemophilia in 2021. You see the citation below. The aim of the study was really to investigate what was important and what were the preferences of patients regarding gene therapy. How do they make decisions? So we created a CVR survey. It was a discrete choice experiment, but it was a CVR survey 183 men responded to the survey. 120 were hemophilia A, I believe, and around 60 some were hemophilia B. About half of them had severe hemophilia, but we had moderates and milds represented. And the results were that the most important preferences were, when you look at the whole group, were bleeding rate. So 30% said the bleeding rate was important. 26% said the dose frequency, so how often you needed to dose or how long, the effect lasted, was 26%. The uncertainty regarding potential safety issues was 17%, right? So the unknowns of gene therapy was important as well. And the impact of daily life was about 11%. But there were differences noted between hemophilia A and hemophilia B. And I wish I had time to tell you all about it. It was a very interesting study that also showed differences between moderates and severe. In a nutshell, hemophilia B gave the greatest relative importance of dosing and frequency. For them, that was the most important. And persons with hemophilia A, or even the moderates, said that the most important for them was reduced bleeding. So you see a little bit difference among the groups. I invite you to read it because it's really very interesting. But, in conclusion, it's really understanding patient priorities, incorporating patient priorities in this decision, treatment decision, really is very important if you really want to accomplish the best outcomes. Another study that we did also related to gene therapy, but this was more, it was called a mixed method study on patient preferences and shared decision making. These researchers were a little bit more interested in understanding the educational needs of people who were faced with this opportunity, and how they could create shared decision-making tools or education tailored to the needs of the patient. So in this study, 104 men with hemophilia completed, again, a CVR survey that was launched within CVR. 8 had received gene therapy, and the response rate was pretty high. It's usually in the 30s, would be considered good. For our CVR folks, it was 45%. So go CVR participants. And it's just 2 graphs. I understand that they're a little bit small, but it demonstrates what is it really important. So some of the participants, the LEs that responded, was that it's really too early. Why they would not consider resume therapy. It's too early to know all the risks. They want to wait to see what happens. I'm happy with my current treatment. I don't know much about it. It really hasn't been offered to me. When they asked them which of the following things do you worry about gene therapy, people said their side effects or maybe long-term monitoring and follow-up, that it's associated with gene therapy. It's so new, right? Some of them were like, I want to wait a little bit more before I dive in. It's something foreign in my body and I'm not sure how I feel about them. So, really understanding the patient perspective and what they were thinking when they were presenting with this choice. And I think that this is important because it allows us to be able to educate persons with hemophilia and, in all things novel therapies, but we're really concentrating in those things that are important to them, respecting what they value, respecting what their beliefs are, but really addressing the educational needs. All right, so you've seen surveys, right? You've seen data queries that we did when we're trying to understand social determinants of health characteristics within the sample. You also saw how we can actually launch surveys within CVR to understand a problem a little bit more in detail. But what else have we done and are we able to do through CVR? Well, I don't know if you guys remember, but shortly after we launched CVR in 2019, we launched it in March. This was more towards late summer, right before BDC. There was a mysterious vaping illness that were getting people to end up in the emergency room with respiratory issues. And so we did a really quick survey, launched it to what we had at the time were only 87 persons enrolled. No, we had a little bit more. 87 people responded. 16 of those 87 had vaped or used e-cigarettes within the year. 14 of that 60% had experienced unusual symptoms. Most of the common products that they were used were cannabis and nicotine. But what we did with this was we provided education. So it was not, it was not just like, oh, did you vape or you do not vape? And have you had respiratory issues. But in case you don't know, this is a health concern. And if you're vaping and you haven't had, it would alert you to at least being aware of what was happening out there. So again, creating that loop and creating education and awareness about a crisis, a health crisis on real time, What else can CVR do? Again, in May of 2020, so at the launch of of the COVID epidemic, we launched a survey. It was open for about 2 weeks. If my memory doesn't serve me and serves me right. And we really wanted to ask what was their experience with COVID, with the COVID epidemic, and also the mental health. How had it impacted mental health? Again, right, quick research cycles, really to understand, taking the pulse of the community, what's going on in the community, and then acting accordingly. So when we asked people who responded, 242 people responded, the top 3 concerns or 5 concerns were the unknowns, right? How long will it last? Will I become infected? What is the treatment like? People are dying. I'm concerned about that. What about my kids? What about my elderly parents, right? All of that, all of the unknowns. Number 2 was access to medical care. So 34% of them were concerned about that. The third was household income insecurity. So 69 people responded to that, 33%. And then access to bleeding disorders medications and the ability to manage current stress, each of them on their own. 56 people said that it was important to them. So again, taking a pulse, how is our community? How can we address them? I know that at the end, MBDF had daily reports. Dr. Valentino would come and would calm us down, gave us the latest of the science. So what was the science reporting? And so again, we were trying to be a source of information. Another cool project that we did was presented in Athens in 2021 in the Data Summit. And this was really trying to define what poor outcomes in people with hemophilia, what were they, defining them, right? But from the physician standpoint and from the subject matter endpoint. And it was not perfect. I'll admit to that, but it was an interesting idea of how we can use CVR to, again, inject that patient perspective in research, right? Athens was trying to define poor outcomes, and they were doing it with the physicians, which of course have a lot to say about poor outcomes, right? That's what they do. They treat disorders with the idea of improving the health of their patients. But what do patients consider health outcomes? So what they did is they looked at the physicians, they showed them the European Hemophilia Safety Surveillance criteria, and there was 2 ranked from 1 to 14, 1 being the most important to 14 being the least important: cardiovascular events, death, excessive bleeding, hospitalization, inhibitor development, intracranial hemorrhage, malignancy, neurological events, target joints, et cetera, et cetera. So you see all the list there, right? It was open for 7 days and 386 physicians responded. With CVR, it was done quickly. We asked them about, at the time were SMEs, we're now call them LEEs, the age, a diagnosis, are they a caregiver or a patient? And we asked them, what are the upsides of living with hemophilia? What are the challenges? It was open for 14 days and 64 people responded. 55 had hemophilia and the others were caregivers. But it was really fascinating. So that when the physicians were posed with that question, for the physicians, the 3 most important were death, intracranial hemorrhage, and inhibitor development. All very important, right? Target joint was a close 4th, I guess. Very important, right? We don't want our patients to die. We don't want our patients to suffer intracranial hemorrhage that can have devastating outcomes, of course. But when we asked the SMEs, what were the challenges? What would they like to change about their hemophilias? They were like more practical. They were like limitations in my activities, arthropathy, so joint disease, pain, physical health, right? So all the things that are important as well. Of course, they would say that death is important or that intracranial bleeds are important, but they wanted, they were like, whatever makes my life easier on a day-to-day basis. So it was a pretty stark difference. And so when you compared the two, you know, it was easy to see that, you know, where the physicians, of course, death, intracranial hemorrhage, inhibitor development, target joint development were poor outcome. I mean, they're the definition of poor outcomes. When you ask similar questions, and albeit they were not the same questions, patients really wanted to live their life with free of restrictions and of pain, right? So very, very interesting way. So again, you know, another example of the things that we can do with CVR, again, acknowledging what we want to do, which is making sure that the research is relevant to our patients, making sure that they're there telling us what's important to them, what are important outcomes, what are good research designs, you know, et cetera, but also making it, you know, making an effort and making it as diverse as possible. So to the research is not really relevant to them, but it's also representative of the community that we serve. So with that, I'll share with you a little bit of the conclusion. So for me, CVR is a community power registry that really centers research around the lived experience, right? We're collecting lived experience. We're trying to describe that lived experience. We're trying to put it at the center of everything that we do. CVR, hopefully, with the tools that we've built, empowers participants to become active partners in research and also in their healthcare, right? I've heard over and over again, I know I want to participate in research, I just don't know where research opportunities are and how to find them. So hopefully we're creating a process to do that. It centers research in the lived experience. It helps identify research questions that perhaps, you know, we are not aware of. It provides a more comprehensive picture of living with these disorders, not just from the clinical aspect. And it's a valuable tool that can be used by all key stakeholders to improve the lives of people affected by these disorders, right? So it's a very versatile tool. I would be remiss if I didn't say thank you. Thank you to everyone who's involved in this project, all the CVR's participants that have enrolled, trusting us with their information, knowing that we're going to be good stewards of that data and that we're going to create good with it. The Lee and the researchers helping us with the development since day one. Like I said, we've involved the community, and what we've created has been as a result of all those listening sessions and all those focus groups. You know, everybody who has helped us spread the word, I think it's very important. You know, this is a partnership. This is not an NBDF project. Sure, we support it and we lead it, but with anything else that we do, we want something to benefit the community. We want this to be with the community, for the community, so that improves our lives. And everyone else who's helping us recruit, from the NBDF communications department to all of you who are helping us, you know, share what CVR can do with your community. So this is my email address, msantaella@hemophilia.org. We also have a box that is research@hemophilia.org. Any questions or any suggestions that you have, we are always thrilled to hear from you. So please don't be shy, reach out to us. And with that, I'll close saying that Community Voices in Research really is we're trying to record experiences so that they can impact the future in a very Lee-centric manner. Again, that's the QR code that takes you to the landing page, but you can also find us in our website. And with that, I think I spoke really, really fast. I'm sorry if I did. We have I get so excited when I talk about CVR. I'll leave a few questions for Q&A in case anybody has any.
Super. Thank you very much, Maria, for that really interesting presentation on the CVR, what it is, and some of the impact that it's had so far, and the potential for, I think, even greater impact. Just want to remind our audience, please do pop any questions that you have into the Q&A feature at the bottom of your Zoom screen, and we'll put those to Maria. Maybe I can start with some fairly basic questions. I think you've really covered some of this, but if I can just maybe recap with you. So the people who can participate in Community Voices in Research, that would be people who are living in the US, and do they have to be citizens, or if they're, let's say, born in another country and now make their home in the US, how does that work? Are they eligible?
Yeah, so GDPR is a very strict rules, protecting European citizens, people living in Europe and European citizens wherever they live. So at the moment, since this was a very US centric project, we said, let's make sure that our eligibility criteria is only focused, at least for now, the efforts work on the United States. I may or may have not said that, this is open to people with a diagnosis, but also the family members that are not diagnosed yet. So any family member, mom, dad, siblings, really, we don't know anything about them. We know that bleeding disorders has to affect the whole family. The unaffected sibling, watching your brother, your sister, just, live with the challenges of a bleeding disorder. So we're really trying to understand it's beyond the person with the diagnosis. And, we also know that there's a lot of people out there that have bleeding symptoms and have not been diagnosed, right? So we want to capture their experience as well, because we recognize it is important.
Right, yeah. And so within the community at the moment that you have within the CVR, you showed some numbers there. Do you have any idea of the breakdown, for example, female versus male? I know you talked a bit about the diversity or lack of diversity in sort of ethnicity and excuse me, racial background. What about also diversity of diagnosis? I know most of the studies so far have been with people with hemophilia, but what about sort of male versus female and other bleeding disorders?
Yeah, so this last year has been a lot about trying to redevelop or trying to take those concepts that we've proven as being valuable to the community and just making them better, right? That was the biggest impetus on trying to create the new iteration of CVR, was really something that was a lot more exciting, a little bit more intuitive, easier to use. The other one was the CVR was a good idea, but it was clunky and it was not fun. And so, our last year has been about looking at how we can improve it, and really not so much about recruiting or looking or evaluating what is it that we need to do to make it a little bit more diverse, right? So I didn't want to make this webinar just focus on the data, because we can do that anytime. I wanted to demonstrate what kind of things we were doing with it. Having said that, you did see that we have a bigger population of white Caucasian people. Half of them, like 51% of them, are Hispanic. So we have a good representation of Hispanics. Males versus female. Last time, if my memory serves me wrong, it's close to half and half, which is unusual. Usually, you have a lot of hemophilias, and I don't remember the categories per se, but we have a good representation. We do need a lot of different races to make it a little bit more diverse. We need to go out more into the rural areas to make it a little bit more diverse, to really understand, to be able to compare regional differences, to see if our if the programs that we're trying to develop actually, are there different priorities based on or where people live, or et cetera. So
Yeah.
much more attention will be put on that going forward, as we now go to recruit in a more meaningful manner.
And you mentioned that you were interested in recruiting sort of through the HTC networks in addition to the NBDF more traditional networks. If let's say an HTC is keen to partner with you on that, they can reach out to you via the website or your email address. What's the best way to get on
Yes,
board for that?
yes. Thank you for saying that. So, I come from the HTC. Before joining NBDF, I had been there for almost 2 decades. And, as a nurse coordinator, I was asked to do so many things. I have so many responsibilities, so many asks. And so we really went the route of NBDF and helping with the support of the chapters. Of course, have been great champions and great helpers for us, so great supporters. But we started to hear from the HTCs that they will be happy to do that for you, right? It's not really a big lift or a big ask. It's just sharing awareness or sharing information. And so we're starting to do that again in this new wave of going recruit in different places. We are excited to working and partnering with anybody who wants to partner with us. So yes, HTCs, call me up. Find my, I mean, like I said, research at hemophilia.org or also in our website. We're all listed there.
And what about maybe somebody who's treating someone with a bleeding disorder, but they're not affiliated with an HTC? Are you interested in hearing from them as well?
Great point. So since CVR is not, it doesn't go through necessarily the HTC network, we have the ability to recruit people outside of it, seeking care, maybe in other healthcare insurance that don't allow them to go to the HTC network, for example, that we know of a few in California. So, anybody with a bleeding disorder, with a family history of a bleeding disorder, with a brother or sister with a bleeding disorder, are all eligible to join, to enroll. And so the last time I checked, and this I haven't done in a while because this requires a little bit more work. The last time I checked, we had about 30% of CVR enrollees that were outside of the HTC network. So again, that will give us a good opportunity to see about their outcomes and how they're doing for the first time in a long time.
Right. Yeah, that's really interesting. And what about accessing and using the data? Who can get in touch with you and say, I want to study something about the data? So for example, if there's a healthcare professional, somebody at an HTC who'd like to do a study and would like to access information that you've collected in order to try and answer a research question, how could they do that? And can anybody approach you with a request like that?
So there is a process by which we can be approached with that. This is the tool of anybody in the community who wants to use it. So I showed you how we've worked with Athen, we've worked with Dr. Thornburg and the HTC's researcher. We've worked with industry in that discrete choice experiment. We've created CVR surveys, but we've also analyzed the data to try to look for ideas or perhaps inform research projects, future research projects. We've worked with a PhD student who was trying to, who was working on his dissertation, and he's actually going to publish pretty soon, we hope. So, there is a process, and we need help teasing this data. We need help. There are safeguards to ensure the safety and the the data. We don't share patient level data. Our statistician does everything to a certain degree because we don't want to give we don't want to give data at that level, but it's available, and anybody can reach out to us, and we can work with them.
Great. What about a lived experience expert? Is there a way to use the data that the CVR has when discussing their own care with their care team?
Yes, and if anybody wants to help us create more of those data points and data stories, like we're calling them now, they're welcome to. If they think that there's a piece of information that they answered, or if they're wondering if there is, they should reach out to me. I'll be happy to put it in, to develop it and make it as part of the health report, that summary that they'll be able to make. The idea with this is to return, we were doing a lot of graphs in the first iteration of CVR. And, that's good at some level because it's something, but we felt like there was a leap lost between the data that was being displayed and what does that mean? Like, what's the impact? What is the relevance? What are the repercussions of this? So, we're creating a little bit more context around the information that we're provided. But again, just like since the very beginning that we've developed, since day one that we've developed this with the LEEs in mind, anybody that has any great ideas or they want to help us develop something, I'm not saying this just to say it, I mean it, because we want the information that's housed in CVR to help people make better decisions in treatment, to be part of that shared decision-making model, right? To come in armed with not only your story or your history, and what's important to you, but what is the data saying? What does it mean that I'm in so much pain, even though the people that I know or people that are in my age group with my diagnosis are reporting far less? What does that mean to me? And is there anything that I can do to make my life, better, to improve my life? So I think that anything, we're very purposeful in wanting to do that, and we need help to be able to do that well. So I would say any LEs, especially any LEs that want to help us with this, I would welcome their assistance.
Great. Right. And you've been really very clear about how the leads are centered in the outcomes of this and in the completion of the surveys. And you may have mentioned this, but I did want to ask, are they involved in the design of the surveys, in the choice as to what the survey investigates, and then I guess also in the dissemination and recruitment of participants?
Yes, there were when this survey, the only addition that we did to the survey was the social determinants of health. But since the very beginning, they've been involved in helping us, understand what it is that we need to pay attention to. They were the ones who said, if you're asking about joint health of men, can you do it of women too, please? Can you just not leave us out just because people think that we don't bleed in our joints? So, many of the period questions that are there are because of, around the menstruation and about symptoms where they are there because women asked us to put it in there. A lot of the functionality, that health report, people requested to put us there. So, they've been in every single aspect of CVR. We've had Lee involvement. With this new iteration, we asked them what's important. What am I missing? One gentleman from the West Virginia chapter told us, you ask about joints, but I have joint replacements. Like those questions are not important to me anymore. And I thought, oh my God, wow, you're right. And so we modified that question based on his input. So, we're always looking for people to help us create something that makes sense to the end user, which at the end of the day is the LEE.
Great. Yeah, it's really responsive. A very technical sort of a question, but let's say someone is participating in the CVR. If a new survey comes out that they can participate in it, do they receive a notification? Is there a way to know that there's something new out there?
Yes. Not yet, but they will. So right now we only have the baseline survey will be launched in the month at the end of February, around there. Eventually we will have a section that will ask the participant, how do you want to know? Do you want to know if there's new opportunities in CVR, and how do you want to be notified? Do you want to be notified via text? Do you want to be notified by an email? Right? The participant will have control over everything. And so if you decide that you want to know about every single opportunity, we will tell you, knowing that, there's a cadence to it. There's not something new every day. There's a certain cadence to it. So that's one of the new iterations that is coming soon, is how would you prefer to communicate with, how do you prefer for us to communicate with you? And they will receive notifications accordingly.
And can those notifications, can they elect to also find out or be informed if there are results, if studies are published or information, things that come out of the CVR, as well as the requests for them to provide information into the CVR?
Absolutely. Part of what we wanted to build with CVR is just closing that loop. I participate in research and I never know what happens to it. Well, now, anything that we do with CVR or CVR related data, we will have a section that's called My Impact that will summarize. It'll link to the paper or link to the publication, but it'll summarize in layman's term what the publication was about and what were their conclusions. So anytime if that person elects to understand that, to know that, they'll get a notification for that as well. So very much controlled by the user and what they want to get from the experience.
Great, super. Well, thank you very much. I think that wraps up our questions for today. I'd like to thank Maria Santaella for sharing your expertise and your time with us today. I'd also like to thank all of our participants in the audience for attending. This recorded webinar will be available on Friday, February the 2nd at hemophilia.org under the Events tab. If you select past events, you will find all of our archived webinars there. Also available in the Events tab is the schedule of upcoming webinars in this series. Join us next week for a presentation on an exciting initiative of the Pathway to Cures program. Thank you for joining us this afternoon, and have an